Everyone, my name is Kendall Benson, and I am the organizer here at NAPW, where we work to ensure that no one is criminalized for the outcome of their pregnancy if they have an abortion, miscarriage, stillbirth, or give birth, and that no one has their rights taken away when they become pregnant. I want to thank you all so much for joining us for our NAPW Student Series webinar, Black Birth Matters, the Case for More Midwives. Our student organizers are awesome. I just want to give them a really big shout out. They envisioned this webinar, they crafted the topic questions, and worked really hard to get the work out. Without further ado, I want to introduce Efe. Efe Osaren has been a doula since 2014. She has completed her training and certification as a full spectrum doula with DONA and the Doula Project and Ancient Song Doula Services, as well as direct entry midwifery apprenticeship with Maternidad La Luz, Borderland Birth Education Advocacy Project, and Daikora Sumda Midwifery. She has served over 200 families in Houston, New York City, and El Paso, and she is currently a full-time doula completing her nurse midwifery degree. As an avid reproductive justice and birth justice advocate, Efe is the founder of Doula Chronicles, a reproductive education platform for communities of color that focuses on holistic uterine health and reproductive justice education. She is also the co-founder of Homecoming, a collective of BIPOC, queer, and trans birth workers and healers. In the future, she aims to return home to Nigeria to provide midwifery support. She likes solo traveling, riding her bike throughout the city, and hot yoga without the Bikram.
Greetings, everyone. Thank you so much, Kendall, and all of the student organizers for putting this together. This has been really great. I really love all the social media action about this webinar today, and I'm very happy about the number of people who are here. So we're going to get started. Black Birth Matters, the Case for More Midwives. Before we start, I want to acknowledge someone who we lost in our community here in Brooklyn, New York. Her name is Shaeja Washington. Shaeja passed away giving birth to her child on July 3rd, July 3rd. There is going to be a protest action movement tomorrow in front of Woodhull Hospital where she was killed, to help support her family and to also bring more attention to the maternal mortality crisis that we're seeing in New York City and national as well as global. So feel free to leave comments and so forth about what Shaeja's life or what people similar to Shaeja's life mean to you.
So what is the role of a midwife and what exactly is their job? So a midwife is similar, not like, but similar to an obstetrician. We help women and people and birthing people give birth to their children. We help educate them and we provide that space. So we are the main healthcare provider for that person throughout their pregnancy, throughout their reproductive life. What kind of training does a midwife have? So there's several different ways of learning to be a midwife. You can learn through apprenticeship, which is how I started off, where you study underneath a license or a more traditional or a more experienced midwife. You can also go to get your master's in midwifery. You can also learn it by trade. But those are most of the two options: is apprenticeship and then university. Are they associated with hospitals or do they practice independently? Both. So you can have nurse midwives who practice in the hospitals throughout the state, and then, certified professional midwives and also certified midwives. So there's CMs, certified midwives, CNMs, certified nurse midwives who practice in hospitals, but they can also practice in homes. And there's certified professional midwives practice in homes and birth centers. How is a doula different than a midwife? A doula is a person or a practitioner who is going to mostly support you during your labor and provide the education. So many doulas have different types of education and backgrounds and continuing education, but particularly they're helping with the labor, where your midwife is the actual healthcare provider. So they're the ones who are doing all of the medical procedures. Should a doula have to act as a bodyguard for the client? No. we don't want to, but we currently are because it is a crisis right now that is happening in our country with maternal mortality. So doulas have been coming into these hospitals and creating spaces to where we are resistance a little bit from the medical system. What role does a midwife have in the greater community? A midwife, well, in the past, midwives in the community were community midwives. So you would have a midwife in your neighborhood, in your community, in your hood, wherever you were. And that was the person who delivered the babies in the area. And so you would have grandchildren and great-grandchildren, parents all would be born by that same midwife. And you would have one throughout the country. But currently right now, we have less access to midwives due to many reasons. But generally, it's a midwife who is providing someone who is providing cultural competent care for you. Often they know you, they know your family, they're in your community. Usually, sometimes they are often of your same race and cultural background or religious background or of your ethnic background as well. Questions about what is the role of a midwife? Or any of the questions that I had, feel free to either put in the chat and Kendall can read it, or you can take your mic off and also talk to me.
I'm actually not sure if we have the mic option set up right now, but I can definitely read any and all questions. We have a bunch about apprenticeships, and I'm not a student midwife, so I don't know what a preceptors are, but we're going to talk about that later too, I know as well. One question I actually have is, do you see a lot of doulas becoming midwives, or do people become doulas and stay doulas and become midwives and stay midwives? Is that almost a trajectory, or do people tend to gravitate towards one or the other?
It's all of the above, particularly in the Black, Brown, and Indigenous communities. What we have been seeing is more people becoming doulas because we are not able to access midwifery or the midwifery licensure of where we live. And so that is possibly why you're seeing more doulas become midwives, because it's kind of our starting point where we would like to have started as midwives, but didn't have the particular access to immediately go there. And then there's people who, go through nursing school and decide that, oh, this is the part of nursing that I want to do. I want to do midwifery. I did an L&D round during my residency and I really liked it. And this is how the role that I want to go through.
And Christine Gibson has a question regarding the doula bodyguard question. How can we as doulas slow down the induction rate? And also for people who maybe don't know what that even means, being a bodyguard, why would a doula have to act as a bodyguard, Efe?
A doula would have to act as a bodyguard, and particularly in hospital situations, because we have our clients have these things called birthing plans or birthing goals. So you make this plan of what you like your birth to go. It could be things of, I don't want an IV, I want delayed cord clamping, I want to push in a different position, etc. And oftentimes we're the ones who are trying to implement that birth plan. And so the client can give that birth plan to the nurses and the doctors, and they can negotiate whether you can do what you want with your body. And the doula comes in and says, no, she has the right to say yes or no. And sometimes it can get volatile. Sometimes it can be an argumentative situation because our protection is over the client. And so that is the case where we are becoming the bodyguards to try to make sure that they're being able to get what they need and their rights are being respected. What was that second question or the first question?
Second question is Christine's question, which is regarding that bodyguard question. How can we as doulas slow down the induction rate?
Induction, like with Pitocin?
I don't know. That's a good follow-up question. Christine, if you want to jump in the chat and tell us if by induction you mean Pitocin. And also, for those of us who don't know, what does induction rate even mean? Or what would it mean to be induced? And what is Pitocin?
So Pitocin is a drug they use to either start labor, to induce labor, or to help the uterine contract. So sometimes it's often used postpartum to help contractions of the uterus.
And Christine just dropped in the chat. She said, my clients get pressured to induce all the time and they ask me for advice and I don't know how much I can say to them to deny the induction even though it never goes well.
So a lot of that part of happening with inductions is to make sure that they're educated on what an induction is. There's tons of articles. I like to recommend evidence-based birth to learn more about inductions. Generally, what I have people do is tell them to go in to do a non-stress test, an NST. You find out if the baby's okay, you find out if you're okay, and if you can continue to be pregnant until it's time for the baby to come on their own. And if you pass that test with flying colors, you can deny your induction. You always have the right to say no to most, if not all, procedures, unless it's a life or death situation to where you no longer can yourself advocate for yourself.
And then one more question that kind of is right there along the lines of difference between a doula and a midwife. Can you talk about the role of midwife assistant?
Yes, so the midwife assistant is the person who is usually going to set up the birth equipment, help the midwife go through her bag, help her do IV draws or blood draws, give medication, check the baby's heart tones, check the mom's blood pressure, so her also checking her vitals, maybe charting throughout the birth, so writing down what's happening and keeping times and tips of everything. So similar to what a nurse is doing for obstetrician in a way.
And we have one more question. We have tons of questions, but so many good questions, y'all. Keep them coming. How frequent is the induction? How frequent are inductions done here in New York? So what does that rate look like? Is it higher than national? Is it lower? Does it need to be as high, or is it too low?
I don't know what the number is. I don't know if there's actually been a study on it. I will say personally for my own clients that I would say maybe 90% of them get asked about inductions and 75% of them go through with it. Yeah, but it's a very high number. Often around 39 weeks or 38 weeks, they start the conversation about getting an induction, and hardly they ever get to go past 40.
Okay, well, I think we have some other questions, but they might be better suited for some of the later slides.
Yeah, definitely. We're going to cover a lot today. So if you feel that your question may get covered in the slides, maybe hold on to them to the end, and then we could see if it got addressed or not. Yeah. Next one, what does home birth look like today? How long does labor take? This is an interesting question because everyone's always curious how long labor takes. I usually answer with the longest labor that I've been a part of was 72 hours. And the shortest labor I've been a part of was less than 10 minutes. So it could be days, it can be hours, it can be minutes. Labor is going to take as long as it needs to take. How long is a midwife at the home birth? So the midwife usually shows up when you are in active labor. So active labor is when your contractions are usually around 5 to 4 minutes apart. They're more tense and you're less vocal and so forth. And then they're there until a couple hours after the birth. And so after they have the baby, they're there to deliver the placenta. They're there to cut the cord. They're there to help you navigate postpartum, the immediate postpartum. So that first hour, breastfeeding, putting the placenta away, all of those things. Doing a newborn exam and also checking on the mom's vitals and so forth. Oftentimes, I would leave a birth maybe 2 to 3 hours after they've had the baby. And the birth center, I think, at least here in Brooklyn, the time limit is 4 hours after birth. Can the midwife give you pain medication? No. The midwife cannot give pain medication in a hospital. Some birth centers do allow gas, nitrous oxide. I think hospitals as well, but that's not necessarily a pain management. That's more of a pain management than pain medication. What happens in case of an emergency? It depends on the type of emergency that's happening. Often midwives are trained to see an emergency before it becomes an emergency. So we know if you are a client who may have a hemorrhage, we know if depending on what the baby's position is, or we know if we're checking your blood pressure and your vitals and so forth. So it's very rare that emergency that is happening in the home that we did not see happen to where we can help transfer you to the hospital before that happens. In cases where after the baby is born, it's usually probably the emergency that you would see. In midwifery school, out of, I don't know, 300-400 births that I witnessed, maybe 10 of them went to the hospital and no one died. What are the benefits of giving birth at home with the midwife? So the benefits of giving birth at home with a midwife is having autonomy over your choices, over your body. You get to be at home. It's really nice to deliver a baby in the bed and then afterwards sleep in the bed with your baby, and not have to worry about getting in a car, transferring home. People, and you can also have your fans and your family present. You can eat whenever you want to eat. So you can eat however you want to eat, what you want to eat. Your midwife is often there with you, the comfort of your home. You can walk around, you can move around, you can use things in your home. So the benefits. Any questions about this slide, Kendall?
You mentioned you can eat what you want to eat. Isn't that true in the hospital?
No, it is not true in the hospitals. There are some policies, I will quote policies because they're not law, so you can still just say, I don't want to listen to you, but then that's where you create a more volatile climate with your provider and yourself. But in the hospitals currently, especially if you're being induced, once you are getting induced and you're on the monitor, it's fluid, it's just liquids. I've even had some births where they wouldn't even allow dark liquids. So like we weren't even allowed to drink bone broth. It was just like water, like Gator or something that you can see through. So yeah. I've had clients eat like oxtails and birthday cake and burgers and whatever they wanted to eat during a home birth, where in a hospital, you're not necessarily able, or you have access to be eating those foods at home. All right, so moments of joy. This particular slide is the larger reason why I wanted to do this webinar because, I mean, especially today, we've had a lot of media around maternal deaths, infant deaths, and mortality and morbidity issues. And it puts a lot of Black women, a lot of brown women in fear of having their child, in fear of being pregnant or not wanting to be pregnant, not wanting to go through pregnancy because everything is telling you that you may die. And so what moments of joy that I can share with you in attending a home birth is what I would like to see more of. I want more midwives talking. I mean, I know midwives always do it, but I would like to see non-birth workers talk about the joys that we see in home births, where like even the 72-hour labor that I was at, it was at a hospital, and we met with her parents and his parents. We played games, we watched TVs, we did things, or at home births where we're cooking large meals. Like I've been a midwife assistant where I'm helping cook a meal for a client with their partner and their mom, and she's in the room. I really like being able to set up altars at a birth at home where we can create a space for them. I like seeing siblings catching babies. In midwifery school, I had either younger siblings as young as 3 years old catch their sibling, as old as I had a twin mom. No, the mom was a twin, and her twin caught her sister's baby. And so when I say catching, it means that as the baby is coming out, instead of the midwife or the obstetrician pulling the baby out, what happens is that the midwife either guides the client's hands, glides the partner's hand, or glides whoever's catching the baby's hands and helps the baby transition to the other side. I've seen things like music. I don't know if you guys seen, sometimes you see TikToks of like pregnant women dancing. We see those during labor. I've done the cha-cha slide during labor. I've done the Macarena during labor. I've done many things. And a lot of the parts of joy is also just to recognize that like you're still having your normal parts of your life during labor. It doesn't necessarily mean I need to lay in bed and let this happen to me. The opposite of what midwifery brings is that you are a participant in your birth, you're a participant in your labor, and you get to set up the design of what that looks like for you.
It sounds like there's a lot of movement and a lot of participation, and even just like those little moments that you shared just then. Do you find that participation is lacking in the hospital, or is lacking in, or the movement's lacking in the hospital, and that these things are easy to come by in home births? Or are you like, no, wherever there are midwives, there are moments of joy, and wherever there's Black births, there are a moment of joy?
No, yeah, it's in the hospital. It is lacking to have movement. Often the hospital rooms are smaller. Often you're on a monitor, so we have this much space to move. Or if you're moving, then they can't get the heartbeat, and so they don't want you to move. They want you to lie still. If you have an IV, if you have Pitocin, you're full up with more fluids and drugs that where you don't have the same energy to do those things. And so it is a lot more restricting in a hospital.
Why is that? Does it make medically more sense to be lying on your back when you're in labor? Or like, how did we get there? Because dancing and doing the Macarena sounds like a lot more fun than being hooked up to an IV.
Yeah, I won't go into how did we get there, because we definitely had some homework before we got to this webinar on the racism in gynecology and the history of gynecology. But in terms of currently right now, it's practices that aren't evidence-based, that are just being passed down every time in medical school. I'm not sure what happens in medical school. I've never been, but I feel like they're not really discussing what a physiological birth would happen. So when they do start practicing, they're just practicing things that they learn in books. And I've definitely met obstetricians who never seen a vaginal birth or a natural birth or a home birth at that. And so a lot of the practices are just due to what they've been taught, and what they've also been put fear in about midwifery as well.
Do you have any other just like favorite moments that just will always stick with you?
Yeah, I had a birth in midwifery school where we were laboring for maybe a day and a half. There was a first time mom. First time babies take a long time. And so we always called it this really long marathon. And so we would take naps in the midwives room, and then we would come back to the birth room, check on and do vitals, check on the baby, and then go back and sleep, come back and forth, whatever. And there was one time I was coming in, she was fine. She was like, I need to go pee. This is baby midwife stuff. Most grown midwives would know, like, if you're getting on the toilet, don't leave. But I didn't really think anything of it. I thought she was just going to go pee. And then I'm yelling from the other side of the birth center. I'm like, hey, are you okay? And I don't hear anything. And then I start walking back. I have like a coffee in my hand or something. And then her partner runs out the room, and he's like, I think she's, grunting. And like, I throw the coffee down, and me and the assistant and the other student run into the room, and the baby's coming out, and she's standing over the toilet. The partner grabs the baby, and then I immediately help, and we pull the baby up. And it's like, it just happened within like seconds. Wow. And the same thing with the placenta. Like the moment she stood up, placenta like dropped, and within like half a second, I was able to catch it before going in the toilet. So yeah, that's one of my joy moments. I know that sounds pretty scary to people.
I mean, we're getting lots of, that's amazing, fast reflexes, love it, ha-ha-has, oh my gosh.
Yeah, but midwifery requires you to definitely be on your toes at all times, because things can take a turn at any time, for sure.
I have one more question that I feel like some people might be thinking. I think when some people think home birth, they think, and you mentioned earlier, no pain medication except maybe gas in some instances with birthing centers. So home birth almost sounds like pain. And how can you have joy if there's all this pain? Isn't that scary? And doesn't that hurt? So how do those two things coexist?
I mean, I think of it like just your daily life. You're not going to be in a complete happy state your entire 24 hours of a day. You're going to be sleepy, you're going to be angry, you're going to be sad, you're going to have joy. It's similar, right? And in terms of pain, like I like to say to my clients, think of like when you hit your toe on the coffee table and you immediately scream out, you want to throw the table away, you're just mad that you hit your toe. That's not the pain that we don't use that definition of pain when we are talking about birth, because it is a different level of, I guess it's a different level of pain, yeah. And it's a gradual thing. So one, it's something that you're getting used to. So if you're having a physiological natural birth without any interventions, you're at home and so forth, your body is going to start having these contractions gradually. You may notice your first one. I noticed a contraction. Maybe you had Braxton Hicks before. You start to get used to it. And especially if you already had cramping throughout your menstrual life, right? And as it gets more intense, you learn to build the momentum with it. And so we work on, you have your doula present, you have your partner present. We like to introduce lots of oxytocin and presently while you're in labor. So that love hormone, the more oxytocin you get, the more that you can feel comforted with handling the pain as it's happening. So the pain is manageable. It's not unbearable. You're not going to feel like death. It's not like a car accident. It's birth and it's labor. So we have to change our relationship to what pain means and realize that it comes with a nuance of different emotions.
That's so cool. Thank you for sharing. Okay, busting the myths. Bust the myths.
Busting myths. So can you be more knowledgeable about available birthing options? I would say, you guys, let me know what myths you think, or not myths, but what do you think is happening in childbirth that I can burst that myth for you, at least. I think the biggest one is emergencies. A lot of folks are very terrified. I've had one where the cord is wrapped around the neck. I get that asked all the time. What happens if the cord is wrapped around the neck? Is the baby going to die? Do you go to the hospital? And my answer is, we just unwrap the cord. It's the fear around the cord wrapped around the neck. I don't know where it came from or what the knowledge of it is. It's a lot of times I'll see things on social media. It's like, oh, the cord's wrapped around the neck. They had an emergency C-section, right? Where in a home birth situation, if the baby's coming out with the cord, we unwrap it. So I had a baby with the cord wrapped around 4 times in midwifery school. And how we're able to tell if the cord is that as the head is coming out, and as the face is coming out, the baby is going to rotate its body. And depending on which way they're rotating, if they're rotating, I can move my hand in and feel around the chin, maybe around the neck. And if I'm, a good midwife, I can tell the difference between baby fat and I think that's a cord, right? And so as I'm feeling at a cord, as the head is coming out, what we do is I will keep the head close towards the pelvis as the baby's pushing out. That way the cord doesn't get stretched. And once the baby's fully out, I unwrap the cord, and I unwrap the cord, and then I gave the baby to mom. There's sometimes where the cord is wrapped tight around to where there may be some time where the baby takes a while to come around and breathe, and that is where we start doing things to help the baby come around and breathe. But cord wrapped around the neck is very, very normal. It is a normal part of birth. Did any myths get posted?
Yes, they did. We have, which I think we're going to answer a bit in the next one, but so maybe you just answer it now, we glide over it later. Is it safer to give birth at a hospital?
Depending if you're Black or not. Yeah, it's a very candid thing. It's if you are high risk, and I give it with a quote because an obstetrician will label you high risk for many, many things. And often right now, geriatric pregnancy or maternal age is considered high risk. Oh, you're over 35, you may spontaneously burst during birth, so you need to be at the hospital. I don't know where they came up with that. But I always say that if you are interested in having a natural vaginal physiological birth, let a midwife do your risk assessment. That way you're getting something pretty even keel about what your actual risks are. But no, it's not safer to give birth at a hospital or at home or at a birth center or elsewhere. All of that depends on the health of you and your child.
And how would you advise someone answer that question for themselves? Like, how does a person look into themselves? Do they talk to a doctor? Do they talk to an obstetrician and a midwife? Do they talk to a midwife? Like, how do you advise someone find out that answer for themselves if it's different for each person?
Yeah, I mean, I guess it would depend on why you are asking those questions. So if you have, maybe you have, you've had gestational diabetes in your family or high blood pressure in your family, you're trying to figure out what that risk is. I often say that in the beginning of your pregnancy, if you are seeing a midwife, the midwife is able to check on those things as you are progressing in your pregnancy. So I learned a lot through apprenticeship where we had a client who was showing signs that she may have gestational diabetes. We immediately put her on a very strict nutritional diet, really watched her closely, checked her every week, and she never developed gestational diabetes, right? And so we're in a hospital situation, you're not necessarily, or with an obstetrician, there's not much time or that continuity of care where you're working with the client. So it's just going to go straight to medication and so forth. So a lot of it depends on what you're wanting for yourself. And what your health outcome is looking like.
We have a question from Dana. So for busting myths, can you talk about the risk of past due date, post due date, mature, overdue pregnancies, and meconium aspiration in a home birth?
Okay, I'll start with the due date. Your due date is not real. It is a myth. Babies come when they come. I say there's a due month, maybe, depending on what time of the month you do. If you are not intervening with like an induction or so forth or cesarean, there isn't really a date that when you can say when your baby's coming. If we knew when babies would come, then we wouldn't have, 72-hour labors and so forth. What was the other parts of it? Aspirating meconium?
In a home birth.
In a home birth. Oftentimes, if your water has broken and your membrane sac has broken, we are checking the color of the membranes of the fluids coming from the sac, and we're checking to see if it's clear, if it's a little bitty cloudy, if it's a little yellow, if it's turning brown, or if it's getting thick, or if it's maybe light. If it is getting very thick and it's very dark, that is considered like we're going to transfer you to the hospital. But we are checking to see what that looks like. And oftentimes, if the baby is born with a lot of meconium, often there were signs of distress that were happening. So we often transfer for a sign of distress that could cause the meconium.
And we also have, Andrea's also asked, I'm not quite sure how to phrase the question. It says, water being broken in casual birth. So is that the same thing that you're talking about? Is there a fear of water being broken in a physiological birth?
I don't know what really that means because your water breaking or your membrane breaks spontaneously or can break spontaneously.
Oh, sorry. It does not say, everyone's saying Kindle. It doesn't say casual. It says CAUL.
Call.
Call, yeah. So I'm sorry.
Are they asking if the baby is born without the water being broken? Yeah, I mean, if baby is being born without the sac broken, we deliver the baby in the sac and then we pop the sac afterwards.
So that answers.
So your membranes does not have to be broken in order for you to push the baby out.
Thank you, team, for helping me read that correctly. And then we just kind of have also a casual birth question. I don't know if this is so much busting myths, but why are the contractions so different in each birth? With my first, it was gradual, not as painful, and my second was so quick and hurt so bad.
Well, practice. So the more times that your body has been through this, the easier it is because it kind of knows what to do and you know what to do as well. Your first time having a baby, your uterus is a muscle and it has to contract, it has to get strong and all those things. And it can take time as well as the sending of the baby, the stretching of the cervix, the dilation of the cervix. All of those things are happening for the first time. Now, the second time, it may be quicker, maybe not. I've had clients who have short first-time labors and longer second-time labors. But definitely the third or the fourth or the fifth baby, those babies are coming out a lot more quicker. And a lot of that's just due into you've been through this before.
Body's like, I remember this.
Yeah.
You got to help me with some more of this language here. Advice for those who have precipitous births?
Precipitous birth, yeah. Advice, breathe. Yeah, I think the biggest advice for precipitous labor is the biggest shock is not really knowing what's going on because it's happening so fast. And so clients that I've been with who've had precipitous labor, the biggest thing we're just focusing on is just continue to breed and continue to try to stay out of panic mode, which is kind of hard to do when everything is happening without your consent, right? All right, who would benefit from giving birth at home versus at a hospital? People who want to give birth at home, or who want to have a vaginal birth, or who want to have the safety of their home, who want to have their entire family present with them, who do not want medication interventions, who are fearful of going to the hospital for whatever that reason is, can benefit from giving birth at home. What rights of value do in a home birth that are not always protected at a hospital? I think we answered that earlier, but being able to go with your birth plan. Often in a home birth situation, your midwife is not going to say, oh, you can't do that, you can't do that, you can't do that, you can't do that. The conversation is going to be more of an open-ended question, like, oh, if you want to do that, this is what we can do. Or if you're not able to do that, it's like, well, we may not be able to do that, but we can try this. And so it's never a good full, no, this is not what's going to happen, and then nothing. It's always a conversation because this is about you and what you are wanting, not what the provider wants. So a lot of those rights that you're thinking of that will get denied in a hospital often don't get denied in a home birth situation. If they are denied, it is because of your health outcome or what could possibly happen.
We have a quick question before you go to the next one. This is from Sophie. Sophie said, I'm in nursing school and I'm hoping to work in L&D, labor and delivery. What is one thing you wish L&D nurses were trained in / aware of to promote better birth?
I wish L&D nurses were trained in childbirth education. Childbirth education, as well as practicing being a doula. I think they need to get better bedside manners. I've often seen L&D doulas try to mirror an obstetrician, and so very blunt, very rushed, very impersonable. And so going back to, I would say, like, be a doula with nursing skills if you can. You know, so especially baby nurses, I've seen the way baby nurses handle babies, and I'm always just like, just slow down. The kid just got into this world. Everything is pretty crazy for them. You are the first person touching them. It is a good time for you to kind of introduce them to the world in a gentle way. It's similar for working with the client or the patient, yeah.
Sophie said, doula training is what inspired me to go into nursing school. Glad I'm on the right track.
Good. Yeah, I would definitely recommend doula training, learning childbirth education, and being around pregnant people and listening to them telling you what they want you to do for them. And if they say no, you either stop or you ask them or you have a conversation about what you're about to do. But that can be very difficult where nurses who are going against their boss or the charge nurse or the obstetrician and so forth. So you got to figure out, either how to play the school at the door or how to be that person in your hospital who's going to, shift the policies in the hospital, because if it is not equitable, if it's not healthy, and they're requiring you to do it, you should not do it, especially in the times of what we're in right now. Just following orders, even though it's harming somebody, is not the way to go.
And Takia has one more question that I think could also fit under who would benefit from giving birth at a hospital versus at home, which is it more cost effective to have the baby with a midwife and a doula than an OB? So what does that cost look like? Because that can absolutely be a factor.
Yeah, the cost definitely depends on where you are and the type of midwife you hire. I'm going to speak on New York City. The cost of a home birth can be anywhere from $6,000 to $12,000. You may pay out of pocket $2,000 of that. You may pay out of pocket for all of it, or your insurance may cover all of it. In a hospital, the births can be anywhere from $20,000, $30,000, especially if you had a cesarean, especially if you're day 3, 4 days in a hospital and so forth. They can get really, really expensive, and you don't know what you're being charged for. You don't know how much it's going to cost. You can't really budget for it. It's kind of like a surprise that comes in the mail 6 months after you have the baby. And it's like, here's your bill. You don't know if your insurance is going to cover everything or what it's going to look like. where with the home birth, you kind of have all the costs up front and you can negotiate. And especially if you are in a space where there are a lot of community midwives, I always tell people, if you're wanting to have a home birth, but you're unsure how to pay for it, just consult your midwife and let her know that I'm unsure how to pay for this. How do I do this? And they will be able to help you more on how to navigate what that looks like. It's very rare that a midwife tells you, no, I can't help you, go to the hospital. How are people who use drugs and give birth treated differently at home with the midwife at a versus a hospital? I'm assuming we mean substance abuse drugs.
I believe so.
Yeah. They are treated like criminals. They're treated like they're treated like how people who are substance abusive without being pregnant. And when you're pregnant, it's even worse. Often ACS can get called on you, or CPS, depending on what's called in your state, where they bring a social worker in to see if you're fit to have your baby. Often, especially Black moms, they're drug tested without their approval. And if you have anything in your urine, then immediately a social worker is called, and you could possibly lose your child right after birth. Where in a home birth situation, that is a conversation that you have with your midwife. We do not test your urine for drugs without your consent. Often it's a conversation we do during a consult. You let us know if that is something that we should be concerned with. If it's nothing that you can be concerned with, then that is your business. Our business is making sure that you are safe and healthy, and baby's safe and healthy. But I will also say that race still plays a factor in that. So if you are, if you're a Black woman and you're in a neighborhood where all they have is white midwives and all they have is, this wealthy population who do not understand racism, who do not understand their harm they may be causing, that midwife may call a social worker and say, well, I was trying to help you, and now you lost your child because they don't understand racism, the systemic racism in the system, and so forth. So yeah, it's definitely a possibility at a home birth still. So choosing a midwife full blank is not just what you need to do. You also need to interview the midwife and make sure this midwife is someone who will keep you safe.
Kind of pivoting off of that question, if we could go back for 1 second. What is the impact of treating drug use while pregnant as a criminal issue versus a public health issue?
What is the impact?
Yeah.
The impact on your life, losing your child, going through the system. I had a client who was trying to keep her fourth baby, where she lost the other 3 children through CPS in court. And her fourth baby, she was just going to go to Canada and deliver a baby in a hotel, right, in order to try to keep her child. It's once you have a case on you, it is very, very difficult to fight cases going forward. It's very difficult to close that case. It costs a lot of money. You have to have lawyers. You have to go to court. You have to take off work. You have to be able to do things for your child. Where in the event that if there is a parent who needs help, maybe they're experiencing homelessness, maybe they're experiencing substance abuse issues, maybe they're experiencing whatever the case may be, as a public health issue, what we should do is we should provide resources and solve the issues that are causing harm to them and their child instead of taking the child away. That is not the solution. The solution is, they're experiencing homelessness, or their house is not upkept, or there's not enough food in the fridge. Okay, so let's figure out how we can solve those issues instead of taking away the child. Now we cause more problems for that person and the child going for the rest of their lives.
Because it sounds like when you criminalize drug use, I think people who pass those laws like to think, if we do that, then people won't use drugs. There, we solved the problem. But
people will always use drugs. We should make sure that they use drugs safely. Or we should create an environment and a society to where people are not going to drugs for a space to kind of get away from the oppression of society.
Yeah. And it's just like, then you're not going to prevent someone from using drugs. You'll prevent them from getting prenatal care. Yeah.
Mm-hmm. And it's also to remember that many wealthier populations or non-Black populations are still using drugs and not being tested. Their children aren't being taken away because they have the money, or because no one looks at them and sees, you're a drug abuser. So
We're seeing lots of yes, all of this in the chat.
During a time of healthcare provider shortages, lack of hospital beds, and limits on who pregnant people can bring to births for support, how important to access to home birth midwives. That is so important. In the beginning of all of this, especially in New York City, our midwives were very, very overwhelmed by the amount of emails, by the amount of calls, by the amount of people who want to switch to home births overnight. I heard one testimony from a midwife where her phone just rang 24/7 nonstop, and the emails, she can never get through them, right? And this should also let you know that people who were seeking home births because the hospital, I didn't want to catch COVID, it's also be aware of that. Did you think the hospitals was safe before, or did you think sick people weren't at the hospital before? Why is it all of a sudden now? It lets you know that the real interest in home birth before, or like the real fear of what home birth before, where now those fears aren't as much because we consider that. We consider it safer because, you don't have COVID in your home, so maybe it's probably safer to deliver at home. We found out, we always knew, but the public found out that there was a shortage of midwives, there's a shortage of birthing centers, there's a shortage of places for people to go. We also found out that a lot of hospitals were defunded to build housing and condos and to help gentrification in New York City continue to splurge, where before certain governors and mayors, there were more hospitals in New York City, and a lot of them were closed down because we had too many beds. So New York City was never prepared to ever have a pandemic. And so this was one of the biggest lessons and hard lessons that could have happened. All right, solutions. Because there are solutions.
So many.
Consult Black, Indigenous people of color. We have the solutions, we have the answers, we have the voices. I don't know a midwife or a birth worker who probably does not already have a birth center blueprint typed up in their computer or written in a notepad, or an idea of like what this looks like, or what we should do. So if you are feeling like, I don't know where we should go, I don't know where the solution, often there's a book written about it, there's a study that has already been done, there's a Twitter thread on it, there's a YouTube video, the answers are present and it's with us. Create curriculums that include practices and traditions on how we serve our community. This is a big thing, especially if you're going into nursing school or going to medical school. I hear all the time that many nurses finish nursing school and know nothing about what traditions existed because the medical model doesn't allow for that to be present in there. And so allowing us to create those curriculums and practices, we then can create better healthcare providers. And so there's this narrative that, well, if you had a Black doctor, you'll be okay. But we're forgetting that that Black doctor still went through that same system, and we're all susceptible to being conditioned. And so to break that conditioning, we have to break the education that we're receiving, or decolonize the education that we're receiving. And white supremacy and anti-Black policies in national midwifery organizations and schools. I would go even further and say that we need to have Black midwifery organizations in schools, or Indigenous midwifery schools and organizations, and people of color. Needs to be owned, ran by, and have students of people who look like them in those schools. Currently, right now, there is no, they're trying to create schools, there's no funding for them. But there's more birth centers coming out that are Black owned or POC owned, but in terms of training actual midwives and nurses, there isn't a space strictly for people who look like you.
We have a lot of questions about that topic. And if we go back super quick, for Sage had a question, thoughts on the National Midwifery Institute?
I don't know what the National Midwifery Institute is.
And that's the thoughts on it. Okay.
Yeah.
Okay.
Black and Brown Midwives Preceptors. So a preceptor helps students prepare to be midwives by providing learning opportunities and helping students process their clinical experience. So the beginning of my midwifery care started where I was the apprentice, and underneath the head midwife or licensed midwife or a more educated midwife, she is considered a preceptor because she's the one who is teaching us. And so if we had more students, if we had more midwives who were preceptors like us, it would be easier to go through. Midwifery school for me, where I ended up not finishing because it was a very violent, very racist school that I participated in, Maternal Luz in El Paso, where all of the preceptors were white women. And then I eventually found some brown preceptors, but by that time I was very depleted. I didn't have the drive to continue. I didn't have the funding to continue. Where if I had started with the Black midwives in a Black and brown school or education, I probably would have been finished and licensed by now. The support is much different when you have someone who wants you to win.
So this is our biggest question is, where can aspiring Black midwives find these preceptors if there are currently no Black midwives in the state? And maybe even before you answer that, could you answer what % of midwives are Black from the poll?
Oh, the poll.
Yeah.
What was the bigger answer that everyone put?
I think it was between 2 and 26%. Those were the two lowest ones, and those were the two that I think they're pretty even.
There are less than 2% of Black midwives in the United States. And so even less of those are accessible to be preceptors. Midwives every day are trying to solve this problem where there's kind of like this large gap between age, where we have our elder midwives and we have a very, very short midwives who are working right now. And there's this large coming of new Black and brown students who are coming in, where there's not enough to carry all of us who are coming in. And so we're finding ourselves where we have to either leave our families, drive to different states, live in different places for months, sometimes years, in order to try to learn underneath somebody. There is currently the National Black Midwives Alliance, and they have a mentoring program, which they are also accepting funding for, but trying to create a space where if you are a Black and brown student and you're trying to make sure you have a mentor, a preceptor, especially if you're in nursing school, because that's a whole system in itself, where you can have someone you can speak to really learn from. I had several mentors when I was in midwifery school, where it was very helpful to come home from a 24-hour shift and just give them all of it, because they really understand and they know what's going on with you. But again, there's this many of us, this many preceptors, so even if there needs to be a way that where all of us finally become licensed, and now we are the preceptors, and there's more of us than the students coming in, so that way we can help with those numbers. So I think the biggest thing is supporting your Black and brown students right now to help us become licensed. Remove the barriers that prevent skilled midwives from providing essential care to communities. And those barriers look like, the biggest one is finances. If you are doing an apprenticeship model where you're coming a CPM, a certified professional midwife, there are no federal funding for what that looks like. You have to kind of come up with that money on your own. Or if you're in nursing school or getting a master's, you then have to pay out thousands. We all know how much university costs, and thousands of dollars of student loans now you're required to get. There's also having to leave your neighborhood or leave your home because there's no one around to train you. And when that looks like is if you had children, if you are leaving behind elders that you're taking care of, if you have to continue working, there's a host of things that can keep you from becoming a midwife. I tell people all the time that I had a sort of a privilege to be able to say, because I'm single, I don't have children, and I had the means, or I tried to make sure I had the means to leave New York and go to Texas and become a midwife, because there wasn't anybody who was needing me, where that's not the story for a lot of students.
We have two questions, and I feel like you have answered them. But there are so many folks interested in training to be doulas. I recognize the difference in practice, but what do you see as the gap for Black folks in seeking midwifery? Is it that ability to find preceptors, ability to find apprentices, ability to find, or the cost? Would you say those are the biggest things, or is there?
Yeah, I mean, it's a trickle down effect, right? So if you have less preceptors and you have just students, and then you have people who are looking for midwives, where those midwives are going to be. Think of, if there's less than 2% in the country, they may be like 3 in your state, 1 in your state. And it becomes difficult for someone who wants a home birth with a Black midwife. Where are they going to go as well?
And then we also had the question, and please also clarify for me if you could, the difference between an apprenticeship and oh gosh, now I forgot the word.
Preceptor?
Yes.
Yeah, so an apprentice is a student and a preceptor is the teacher.
Perfect. And how can you find these apprenticeships for midwifery?
So it's not necessarily finding an apprenticeship, it's finding a preceptor. You are the apprentice. And so when you find a preceptor, then you can start your apprenticeship with them. But it's a lot more thorough than what that sounds like. I'm making it sound very simple, but it's more of your midwife, the preceptor is going to, you have to also be compatible with that midwife, because now you are following that midwife everywhere. Your life becomes midwife life. So if you need to know that you're going to be on call as much as the midwife be on call, you're going to go where the midwife is going to go. And so you have to be really up for that lifestyle.
Okay. I think we're good to the next one.
All right, so removing the barriers, so collectives that control how we learn, where we learn, and how we get licensure. So the biggest how we get licensure is a huge political issue in our country that many people aren't aware of until you start seeking a midwife. And then you find out that there's different licensures and they're legal in certain states. And why is that? Why isn't there one type of midwife that's legal throughout the rest of the country? And it's a very political history, which goes into, if you watch that Vox video, they talked a little bit about how that came about. Allow licensing for certified professional midwives in New York State. So currently, right now, the only legal midwives in New York State are your certified midwives, who are only legal in 9 states, mostly throughout the East Coast. And then I think I'm getting that number wrong, so don't quote me on that, 9 states. And that's certified nurse midwife. So where you go through nursing school and get your master's. So you become an RN and then you get your master's in midwifery before you can practice. Where the CM, you can have a degree in anything and then you get your master's in midwifery. But then you're only a limited amount of states where you can actually practice. And the CPM models are allowed in currently, I think, 39 states or 37 states. And New York State is not one of them. And so we have we are trying to push Cuomo to legalize certified professional midwives. And we're also hoping that if New York State can legalize certified professional midwives, one, not only do we get more access to tons of more midwives, because that access, the way to become a CPM is more accessible. 2, the rest of the country would tend to follow what New York does, and we can get more CPMs, we can get more access to midwifery care. If you are aware, midwives are used in the rest of the world as first reasons when you're having a baby versus here. And so this goes into with the high maternal mortality crisis that we're seeing right now, where our lack of having midwifery care or access to midwives. And so having all licensure and having full stop access to midwives can make a huge difference in what's happening in our country right now. Questions about CPMs?
We do have some questions about CPMs. They're kind of all over the place, so it's a little here and a little there. Yeah. Is there a significant difference in the role of CPMs versus nurse midwives, especially in the home birth setting?
In a home birth setting, I think the biggest difference is that your nurse midwife can prescribe medications.
So that's the follow-up question. Do certified professional midwives have the same access to medication or pain management as certified nurse midwives?
So no midwives have access to pain management in a home birth situation, except for, like I mentioned, the nitrous oxide. In a hospital situation, that is done by the anesthesiologist, and you become more underneath the obstetrician care, or you have a congruent care with your midwife and obstetrician. But in terms of, say you get a pap smear and you need something for yeast infection, your nurse midwife can prescribe that in New York State. But it depends on what state you're in. And there's some states where CPMs are allowed to do GYN care and be able to provide resources for that. So along with this bill, we're also asking for that CPMs still be able to get access to the things that they need for clients and not having to refer them back out to the system.
And Efe, would you say it is better for Black midwives to pursue CPM credentials or go the nursing route in terms of credibility?
I think that's a personal question. And it also is a political question as well. It depends on where you live. It depends on, currently right now, CPMs or CNMs have a very large salary gap because there's the hospital pay and I get paid by when clients are hiring me. And so in terms of what is best for a Black midwife, it depends on what you want to practice, how you want to practice, and what that looks like. I think when you start practicing as an apprentice or learning underneath the preceptor, you become a little bit more knowledgeable on what type of midwife you want to be. But if you start the apprenticeship route, I always say, like, even if you're going to go to nursing school, it's really good to like get a few home births underneath your butt before you go into nursing school. So that way you're not, your first birthing experience is not just completely hospital or medical based. You kind of have a knowledge and an awareness of like what actual birth looks like.
Tionia also commented, insurance coverage also makes a difference when deciding to become a CPM or CNM. Insurance
coverage?
Yes. And also
that's also a state question. So it depends on where you live, if the state allows licensed insurance for CPMs or not. But because in New York City we don't even have legalized CPMs, so they can't even take insurance, no. But not every certified nurse midwife can take insurance. There's often insurance doesn't even pay their full fee. So there's also the fight that midwives should be able to get their full fee. Obstetricians are not fighting for their full fee. Why are midwives having to fight for their full fee as well?
And I believe you touched on this a little bit, Efe, but Linda wants to know, why are you choosing the CNM route?
I'm choosing the CNM route because several reasons. When I was going through my apprenticeship in the school, I didn't have enough finances to continue the program. And so that was a reason why I had to pull out of it. And then when I realized that I do want to continue midwifery, I can get student loans, so that was able to do it. And then also I live in New York State, where CPMs are illegal. So in the event that CPMs were legal in New York State, I likely would have never had to go to Texas. I would have never had to go to that school. I probably would have apprenticed with a midwife who was down the street from me, and everything would have been smoother, where I was able to possibly still work or do things or have more support from my community to become a midwife, where because I had to travel out and be in a space where no one knows me, it was more difficult. And so a lot of it, me doing the CNM has to do with the struggles of what my past were. If those barriers did not exist, then I probably would have been a CPM right
now. Okay. I think we have one. Okay, yeah, we can go to the next slide. Hey, I wanted to take a moment to lift up some of the work that the awesome staff attorneys and lawyers have been doing at NAPW, and we support New York Midwives. And so in 2020, and I think Christine was also asking, who should we lobby about legalizing CPMs? Cuomo. I can send these documents that I'm about to talk about so that you can look at that and see who to reach out.
And this website has a lot more information on what that looks like, on how to do it. Yeah.
And I'll also be sending out that link, so in case you all don't catch it now, you can still see it. So in 2020 NAPW, we sent a letter to Attorney General Letitia James, asking her to stop the prosecution of midwives, because it's more than not just saying you can't be licensed. It's saying, and if you practice, we're going to criminalize. that action. Like Elizabeth Caitlin and Melissa Carmen, whose CPM credentials are accepted, like Efe was saying, in 36 other states. And so, and I don't know if everyone caught that, but what's wild is right now during the executive order, and please correct me if I'm wrong, that you have CPMs who can practice in other states. And Cuomo said, and because you all are licensed, quote unquote licensed, you can come here and practice. Oh, but the CPMs here in New York State, you can't practice because you don't have the license, even though those are identical educational credits. It's just literally, that's, we also wrote a fact sheet.
I'm pretty sure he doesn't even know what that even means. Yeah.
Like, what? In 2020, we also wrote a fact sheet on New York State midwifery licensure. So if this sounds interesting to you and you want to get more involved in this, and you say, you're thinking, please give me some more background, you can read that fact sheet, and it helps lay it out. And we also released a statement calling for states to lift restrictions inhibiting home births and birth centers as part of emergency executive orders, like I was talking about earlier, which Efe was talking about. Like, we need to reimburse midwifery care at 100% of the rate of physicians for the same service, whether from insurance or Medicaid. We need to change the scope of practice law so that midwives can practice in all states and territories without fear of arrest. And like Efe was talking about earlier with the barriers, remove the barriers for midwives to practice autonomously and attend out-of-hospital births. So let midwives do their job, don't arrest them for doing their job, and pay them for doing their job. And that just all sounds...
And that goes into what I didn't mention, why we don't have enough birth centers in New York City, because they're unaffordable to open. In New York City, CNMs have to be underneath an obstetrician care, and the malpractice insurance, it's the cost of malpractice insurance for a hospital for one midwife or for one birth center. And you're telling someone who has just a regular small practice to pay $500,000 for malpractice insurance. It's not possible. It's not doable. And so that's a barrier to why our midwives are not able to open birth centers in New York City.
And so also, Efe, it looks like I have created confusion. Stephanie is asking, so are you saying midwifery is illegal in New York State across the board?
No, that CPM licensure is illegal in New York State. The certified nurse midwife and the certified midwife, those are two separate different licensures, are illegal in New York State.
So different paths to become a midwife, and they're saying this one's okay, this one is okay. And then we have another question. Actually, we should keep going, and I'll weave them in.
All right. More solutions, because there's always more solutions. Finance woo-woo, which means for us, by us, organizations and birth centers and midwifery schools. If you go on my website, or if you just go through my blog post, if you feel really up to reading a lot, you will find a list of organizations throughout the country that are needing support, as well as there are op-eds from student midwives who are also needing support. And if you're thinking about becoming a student midwife and you're a Black person or a brown person, you can read those stories of what those student midwives are going through, so you can have a little understanding of what you're going to get yourself into or what things you want to avoid and fix for yourself.
So
go ahead.
I did just drop it in the chat. I would recommend you all click it now so you have it, but don't read it because Efe's still talking. She's still got things to say.
Help fund licensed Black midwives and teach Black students. So, like I mentioned earlier, the more that we can get our students to graduate and become licensed midwives, we can help with that ratio of less preceptors and more students, and also have more licensed midwives where everyone has more access to them. You can also follow me on Instagram, on Twitter. I will definitely be candid and let you know that sometimes Twitter gets not safe for work, but that's what Twitter is, right? The next slide will go into what my socials are. Educate yourself. So I have a really great reading list that I sent Kindle that you guys should probably have. There's tons of YouTube videos and emails that you can also get through in learning. A big part of understanding the maternal mortality crisis in our country is understanding the history of how it started, where it came from, where it's going. A good, short, very brief answer is slavery. But you definitely want to be able to get way more information of what happened in those mean times.
We have gone over time. How did that happen? We also have 20 questions left. Efe, do you want to stay on and answer more questions, or?
Yeah. I have a random day that I'm not on call.
So lucky. And y'all, this is Efe's Twitter and Instagram. I 10 out of 10 recommend following both accounts. And let me just bop around here. We have a question. Is there a Black Midwifery scholarship?
They're coming up, yes. There was, actually, I'm bad at remembering Instagram names, but I got tagged in one today by, sorry, I'm trying to pull up the post.
I can also speak to that. I see in the chat that Megan answered a similar question to Elizabeth and said, yes, many midwifery schools offer BIPOC scholarships. For example, the school I attend, Midwives College of Utah, offer BIPOC scholarships at each enrollment period.
Yeah, so the schools provide some, but if you are not going to school, if you're wanting to be an apprentice, I can't think of if you put in like Black Midwives Alliance in Instagram or Black Midwifery, I wish I could share this Instagram page because it's a new one. But the National Black Midwives Alliance definitely can support and send you in the right direction. But I strongly suggest that you fundraise because there's never enough money coming from the scholarships, almost never, because midwifery requires you to not work, where a lot of other degrees you can have a full-time job and go to school and so forth, where midwifery is you're going to a birth and you're studying, right? And so it's very difficult to also still pay your rent. So they give you money for school, but the rest of your part of your life still needs to be funded.
Okay, is there like a way that maybe we can like thank you for this time and like pay it forward? Like, do you have like a PayPal link or like anything of the sort you can drop in the chat that we could like? I don't even know. I'm just like,
I guess I don't know what my PayPal link offhand, but if you go to GoFundMe.com/Doula Chronicles, you can find my fundraiser there, and then my PayPal link and my Cash App link is there as well.
Stephanie is also saying a friend of mine at Mary Lovejoy does micro grants when she is able, FYI.
Mm-hmm.
So I'm going to drop that in the...
There is huge community support for the Black student midwives. It's not enough, but there is a huge support. So once you start practicing and you get yourself out there and letting people know, currently right now, there's more support than when I started school a couple of years ago. So definitely there's more attention to Black student midwives right now.
Oh, also, please plug Mila saying July 25th at 1 p.m. Mother's March for New Yorkers. There's more information there in the chat, so you can check.
It's going to be in the Bronx.
Yes.
Mm-hmm.
And we have some questions about kind of more about what a midwife does. So do people go to midwives also for help with ending a pregnancy?
Yes. I help assist a miscarriage. I've helped assist a stillbirth at full term 9 months. The miscarriage was at 20 weeks in the home. The stillbirth was in the hospital. We also help with abortions. We have full spectrum. Mm-hmm.
Do you do that in the capacity of a student midwife or as a doula?
Both. I have done abortion doula work, and I've been a doula for stillbirths before, as well as miscarriage, and as a midwife assistant and student for miscarriages and stillbirth.
We have someone who wants to know, what are your thoughts on doula certification?
It's unnecessary. Those are my thoughts. I think getting trained, yes, it's necessary. If you are studying underneath a POC or BIPOC organization, certification can help them stay afloat, so that becomes more of a personal issue where your money is going to help the company. But in terms of giving money to like a really large organization that is white owned and racist, like DONA, I would say no.
Eberre has a follow-up question. Thoughts on state efforts for doula reimbursement? Do you think it's possible to increase access to doula service on a larger scale without perpetuating existing systems of violence?
No. I think what that does is create, just I've always said that doulas are just a Band-Aid in a system. And so if we get hospitals to say, we're going to get more doulas to just help us instead of actually changing the way the maternity healthcare system works, it takes the accountability away from them. They can say, oh, we hired doulas. Why are people dying? Versus, why did your doctor kill that person who was pregnant or pregnancy? And why are the nurses listening to them? And so while having doulas is a good short-term answer, it is not a long-term systemic solution.
We have some questions about the NICU.
Okay.
What can NICU RNs be doing to better support the birthing people you work with?
I think the biggest challenges that I have with NICU is that it's just not parent friendly. There's really, in New York City, I don't know what it looks like. I know I saw a NICU when I was in El Paso and was, semi-nice, but parent friendly. And where are the parents sleeping? Where are the parents breastfeeding? Where are they storing their milk? Where are they pumping? Where are they eating? Where are they able to bring more family members around? It just feels very isolated from a community. I would also say that make sure that your NICU is funded to where they have all the type of staff they need. I'm not exactly sure what type of NICU staff they need. I learned a lot from Katie. She is a nurse midwife, not practicing right now here in New York City. I think her Instagram is Brooklyn Grows, where she was a NICU nurse who talked about what was happening at Kings County and was fired about it, where there's certain types of staff or education and trainings that the RNs did not get. And so they were given incompetent care just because they were not funded to get more care. And these were happening in public hospitals that were predominantly Black.
Yeah. I'm going to drop Katie's Instagram handle in there as well. Megan said, it isn't NICU friendly anywhere. My firstborn was in the NICU and I have supported a few NICU parents as doulas as well. Lots of issues. What role do you think midwives could play in terms of assisting families who end up in a NICU situation?
I think it could be similar to a doula aspect, where they can help in that way, but you have to make sure that you're not creating an out-of-scope practice for your midwife, where a NICU situation, it becomes more for a pediatrician or someone who is caring for the baby. Where the midwife is more caring for you and throughout the pregnancy and the labor and the birth. There is a stop period after certain times where now you need a different type of provider.
I'm also smiling because Katie's in the chat. Hey, Katie.
Oh, yay. So I'm sure she gets to answer what that means.
We also have some questions from students, which makes sense because students just kind of asking if you can impart some wisdom. Can you begin an apprenticeship directly out of undergrad? Is a question from someone who's anonymous. How would you gain more experience before making the decision to go to nursing school?
You can. Apprenticeship is not required to go to nursing school, and not suggested. They don't suggest it as well. The apprenticeship model is something you do on your personal level. So currently right now, while I am taking classes to get into nursing school, I still apprentice, one, because I like it, two, because every time you go to a birth, you learn something. And a big part of midwifery is to remember that you're always a student, right? And so if I take time away from apprenticing, me personally, I feel like I'm going to start losing skills. I have a lot of joy with attending births. So having that space to where I can continue to be a student, even though I don't need to be an apprentice anymore because I'm choosing a different path, it's still necessary for me personally. But I do recommend everyone should go to a couple home births with a couple midwives, and even becoming midwife assistant could be helpful. Even if you're not even going to become a midwife, maybe you're going to just do nursing, go a different path. That knowledge is helpful for your community, for yourself, and for your family.
Chloe is asking, having a non-health related undergraduate degree, I have no experience with clinicals on call. Do you have any advice on how I can make a living as a birth worker while in school?
During a pandemic? I'm not exactly sure. I would say if you have no experience right now, the first year or two is just you're going to be spending more money on learning and becoming educated versus making money. I definitely also wouldn't use the birth worker career to be in a position to make more money, because the system of what birth work looks like, I mean, I talked about it in the Band-Aids and having more doulas and so forth, is not necessarily productive into getting us to liberation of what that looks like in terms of healthcare and maternal healthcare. So if you're going into it to make money, I think you should choose a different career.
And then Ariel has a question that I thought was going to pop up right when you said it. How do I become a midwife's assistant?
How do you take a midwife assistant training? Or you find a midwife you really like, and if she really likes you, she will train you.
So nice. Sage says, I'm going to college in Portland, Oregon, and I know there's easy access to birth work there. Do you think it's to get my bachelor's and midwifery certification at the same time? I think it would be logical to do them at the same time because of the ease of access to preceptors and the security that having campus housing and food would offer.
It can be. I don't know when you will sleep or study, but it can be. Yeah.
Okay. I've tried to make it a little path, but we might just kind of be hitting some questions.
Okay, cool.
Okay, let's do this. Let's go to the top. How can I be a white midwife and an ally? Says Jasmine.
I think I will say this. I don't think this is a space for me to really go into what you need to do. There's tons and tons of resources about how to become an ally in general. I think if you just start there and then start your midwifery, start learning how to be an ally in general within racism and being a white person, and then going in once. The midwifery allyism is mostly about uplifting the Black midwives' voices and uplifting or supporting those organizations that are trying to become more prominent. I think if you're a current midwife right now, calling out ACNM and MANA on their racist midwifery institutions could be a good start.
And Jaleesa has a question. There have been a few articles I've read about how the U.S. has increased C-section deliveries.
Oh, wait, sorry. Before you go, I would say there have been some white midwives who an allyship of supporting Black student midwives. And so maybe you can go into that space. I wouldn't necessarily say apprentice Black students unless you've done the work to the anti-racism work that you need to where you're not going to traumatize that student. But I've had midwives who bought me medical equipment, who bought me books, who bought me meals, who paid my rent, who I had a training with a Black midwife in Hawaii, and I had a white midwife who paid for me to go take that training with that Black midwife, right? And so there's this way of creating, using your resources to get that Black student or that brown student near more Black and brown midwives, or to help support their education by buying the things that they need. Yeah. Go ahead, sorry.
No problem. Jaleesa is saying, there have been a few articles I've read about how the U.S. has increased C-section deliveries in the past few years. Can you discuss any experiences when a C-section was necessary and when a C-section was decided or without reason?
For when it's necessary, I think in terms of when baby and mommy are not doing okay. So it's not that C-sections are completely unnecessary. It's just that they're being overdone. So the question that we should be concerned with are the ones that are unnecessary. So often are the ones that are caused. So often an induction can cause a cesarean, or hospital interventions can cause a cesarean. That is not necessary. So stopping the interventions before that even happens can keep you from getting that C-section. What was the last part of the question?
Oh, I knew you were going to say that, and I just clicked answer.
That's okay.
And was there an instance in which someone had a C-section for no reason?
No, there's almost never a non-reason. It's that the reasons are caused by negligence and interventions that the providers are doing. They're always necessary when they happen, but they're often caused by it. I've never had a client who had a scheduled cesarean with no medical issues.
Is that a thing that you can do? Can you do can't you like opt into cesarean sometime? Isn't that a thing? Where you like schedule your cesarean?
It is a thing. You can choose your birth date if you want.
So in that situation, wouldn't it be that you could have a cesarean with no emergency?
Yeah, yeah. And if you watch The Business of Being Born, it starts off with clients or women talking about how, they were in a nail shop and like, oh, I picked July 3rd or I picked this date because it goes with this date and I need to get married on this date and lose weight by this date. So yeah, you can definitely plan it. Or in celebrity culture, we know that they plan their C-section so they can plan their mommy makeovers right afterwards.
And do you ever, or have you ever seen, as a doula, someone having a C-section where the doctor says it's an emergency, but you're like, I don't feel like this is emergency, but they can say that because they're in a position of power?
Yeah, I have several times. And often it's a lot of fear mongering that is happening to where my voice no longer matters because I'm not the professional in the room. To where now the client is scared for their life and scared for their child's life because of what the provider said to them. They have a lot of tricks to get you to do
one. Alexandra has a question. You already touched a bit on this. Going back to certification of doulas.
Mm-hmm.
Certification, do you think it's important for doulas to be certified? You said no. And how can we navigate that when there are so many different certification services? There doesn't seem to be a uniform certifying process. She said, I understand if you don't have time to answer this, it's not a midwife question. But isn't it? It's all interconnected.
What is a certified? I'm confused on who is requiring certification.
I think it's just saying.
I mean, in New York City, we had last year where Cuomo tried to pass a bill to where they wanted to certify us in order for us to get Medicaid reimbursement. And we pushed back against that because we don't believe in that type of how we practice and our autonomy of that. And so if you, in your community, and they're requiring you to get certified, you can do what we did, and you can say no, you can push back and let them know that this is actually what a doula is. And there's many types of ways to be a doula. There's many types of trainings, and there's no one right answer. What that looks like. But a lot of that depends on the politics of your environment. If you're in a space where you don't have the power of what New York City organizing looks like, and in order to protect the woman, you need to be practicing and certified, then yeah, you should do it. But keep in mind that it's not going to make you a better doula because you're certified.
I don't want to speak for Alexandra, but I'm also wondering if maybe they're talking about being a DONA certified doula versus being I don't know what the other I do know that there are other certifications, but how they're just such a plethora. Like it's not just like one, and how do you choose?
Yeah. And DONA is the most popular because wealthy and because white. And so when you have that wealthy privilege and the power to put your marketing everywhere and to tell everyone that you did it first, everyone's going to go to you. If you Google doula, DONA shows up, And so really consider where that power is coming from with that organization, and is it doing good for you in your community?
Morgan wants to know, and I feel like this entire webinar almost answers this question, so maybe you have a mantra, but Morgan wants to know, what advice would you give to an aspiring midwife?
What advice would I mean, I'm still an aspiring midwife, so I don't know if I can get the best advice. I would say, one, just really understand why you're doing this work and the passion for it, because it is very hard. There are a lot of nights where you're not happy, or you're sad, or you're very tired. Not all births are good. Some of them are really long. Some of them are very stressful. People are people, right? And so really taking to a point that like midwifery is not just a career, it is a lifestyle. And so your entire life has to change. The people around you have to understand it. Your partners have to understand it. Your children have to understand it. There's a lot of factors that go into that. And that's why I really encourage people to apprentice, even if you're doing nurse midwifery, because when you can see what a nurse midwife's life is like, you can learn more about just watching her life as being her student, and how, if this is what you want to do, or this is things you want to change.
And Alexandra also just dropped in the chat to say, thank you so much. I was just concerned about not being treated as a real doula if I didn't get certified, especially as a young POC.
Yeah, I was certified for 2 years, and I got certified my 4th year being a doula. And I only got certified because I was working with the organization that where I created my certification paperwork and turned it in. So it was more of just like I had access to say, hey, sign this, I'm here, here are my paperwork. If I was not in the position of working for the organization that certified me, I probably would have never did it and felt it was necessary. I did let it lapse, and I don't have interest in doing it again. I also don't need to.
Andrea was saying, I'm currently looking for doula training, so happy you joined the webinar because DONA is everywhere, and I was beginning to think it was a necessary evil. That sounds like
it is. No, it's not. No, it's not. If you Google POC, if you go through the Doula Chronicles Instagram, there's tons of different trainings that I have posted throughout the years.
Mila also just wants to give a shout out to you. Thank you for committing to midwifery and making real change at it. So, NBG.
Hi, Mila. Mila is trying to raise funding for a birth center in the Bronx, you guys. I hope she posted her link in the chat.
So this one's more about fears and wishes for VBAC, which is a vaginal birth after cesarean. How to balance wishes for a vaginal birth after cesarean with those fears and risks of being pushed for another C-section for baby number 2, since they already had a C-section with baby number 1.
You find a provider who will do a VBAC for you. If you are really about that life, just do a home birth. Find a midwife. In terms of working through the fears, there are a lot of Facebook groups and meetup groups on women who had cesareans or VBACs or 2 VBACs, or had cesareans and trying to get VBAC. You can search VBAC support groups, or I think there's ican.com. I don't know where that organization is right now. I know it's a very old one, but they can have you. There's tons of resources out there about working through that. I would also say therapy could be helpful too.
We also have a follow-up question. Should anyone watching this take the information shared tonight as medical advice? Would it be correct that individuals should make medical decisions after consultation with a qualified healthcare provider, such as a midwife?
So the first question, should they take what I said today as medical advice? No, because I'm not a medical licensed professional. The second question was,
would it be correct that individuals should make medical decisions after their consultation, like a one-on-one with a person, a qualified healthcare professional, such as a midwife?
Yeah, I mean, your licensed midwife is a medical professional. Yeah.
Wondering if
when I become licensed, I'm not going to be as caring to you guys, so definitely take advantage of it now. Yeah.
Scroll back up. Oh my gosh, Efe, you have straight up answered 37 questions so far. How does it feel?
Feels good. I like talking about birth and stuff, so I can never really get tired. Yeah. That's why all my friends are doulas. We talk about placentas over dinner.
Oh gosh. We have a question. Maintenance of health. This is from Chloe regarding the physical act of being on call 24/7. For instance, how do you ensure that you're performing your best and still taking care of yourself? This is more of a question about midwifery lifestyle and less about money.
Self-care is very big. So really caring for yourself when you're not at a birth, because you are aware that you may always possibly go to a birth. And so your lifestyle has to be healthy. So if you follow me on Instagram, I do yoga, I cook a lot. I ride a bike throughout the city. I have a very active, healthy lifestyle because I need to be healthy and active in order to be a provider. In terms of staying up for 24, we're not actually staying up the full 24 hours. I might have stayed up for like 18, 20 at one point. In midwifery school for a 24-hour shift, we're sleeping in between, checking in with the clients. I may have like 20-minute naps here and there, back and forth, or maybe like an hour nap and so forth. And so, at a birth, I bring tea. I bring, I'm a big hot tea drinker. I bring things to do like crossword puzzles, reading books, have my phone charged. things that will help distract you in the time. And if not, there's always sleeping. One of the midwives that I apprenticed with, the biggest thing she used to tell me is that you need to sleep until you can't sleep anymore. And so, and that was a good learning lesson for a birth, because once you can't sleep anymore, you don't know how long you're going to be awake, and you don't want to try to be awake and you didn't sleep because you wanted to play around, or what that may look like. Yeah.
And Ariel has a kind of a follow-up question. Did you meet most of your doula midwife friends in school? I'm trying to curate that circle.
Yeah, I met them in New York. I met them at different trainings and workshop and conferences. Pre-COVID, New York has a very large doula birth worker community, and we would do different workshops on pelvic floor therapy, or we would do Christmas parties, and there's the Commons Birth Conference and the Black Mamas Matter Conference, and NAPW does, there's always a place to meet birth workers here, and that was kind of how I built my circle.
As a doula, I've seen hospital midwives adopt hospital-based practices that aren't great for birthing parents. However, my experience with independent midwives is that they are much more open to a birthing parents first mentality. Is their training the same? Is it simply practitioner choice about which approach they adopt?
Who's the midwife compared to a doula or an obstetrician?
Hospital midwives versus...
Oh, no, okay. Yeah, hospital midwives versus a home birth midwife are trained differently. So, they're trained differently in a way of, so the CPM is an apprentice model, so they never enter nursing school. And so not entering an institution means you don't get taught the ways of the institution. The nurse midwives that I know that do home births either had home births themselves, learned about home birth before school, or found it after school. So it wasn't in school that they learned about how the model care that they wanted. One of my preceptors that I was with last summer, she had 5 home births, and she had a traditional midwife who delivered her children, and that was how she got it, why she went to midwifery school. So a lot of times it has to do with your experience and what you're around that opens those doors for you.
We also have a question from Jaleesa. In the solutions, do you know about any states that are changing policies regarding safer birthing outcomes?
Yeah, I don't know the exact states of what there is a current federal bill happening called the Momnibus with the Black Mamas Matter Alliance and several politicians that are trying to create a more federal approach to addressing. I think Kamala Harris recently, or last year or so, helped pass a bill for diversity training. Yeah.
I was wondering if you can talk about the barriers for traditional midwives.
Similar to the CPM, depending on the state, traditional midwives aren't licensed or legal or recognized anywhere in the country. And so they're often practicing off-grid. They're not recognized as midwives because they're not licensed.
Ooh, Jacqueline's asking, do you know of any doula trainings in New Jersey? And I bet I know which one you're going to mention.
Well, all the doula trainings right now are virtual. So I would take advantage of taking a training that you would have wanted to take. And, like there's this really great training in Ohio called Root that you can now take because it's virtual. Or Sumi's Touch, she's based in Oakland, you can now take because it's virtual. But in Jersey, the only one I'm aware of is Ancient Song.
Ancient Song Doula Services. Awesome. This is a nice one. Can you speak to your thoughts about midwives and doulas getting training in lactation support?
It's necessary, I guess. Yeah. It's kind of difficult to be a midwife and not know about breastfeeding. So it's a part of the birthing lifestyle. Yeah.
And I think this might be our last question.
Okay.
For Black moms pursuing VBACs, how do you pursue getting a second opinion from a midwife on circumstances before completely switching from OB to midwifery care? Is it just a phone call away, or is there a full chart medical history paperwork, logistical barrier? What does that look like?
It's both. You are getting a second opinion means you're contacting a second provider and they're going through your paperwork or they're questioning you on a consult on what that looks like, to see if they can provide that for you. Yeah. I would go to 2 to 3 different types of home birth midwives or birthing center midwives to do your risk assessment before understanding. And if oftentimes what you're going to have is the same answer from each midwife. And so, yeah.
And speaking of birthing centers, that's a perfect little plug for our next NAPW student volunteer series webinar, which is going to be with Memphis Choices. I believe it's going to be on the 29th. They just opened, I believe it's the first birthing center in, might be in Tennessee, in all of Tennessee, which would be wild. But they have an incredible midwifery model of care where they provide not just abortion and birth services under one roof, but they literally provide everything. And it's beautiful. I almost legitimately started crying when I was like looking at everything, and I was just like, they're doing it. They're doing this radical care. Sandra's asking, what is it called?
Choices is what it's called.
Because they're all about choices. And it's incredible. I really hope you all can join us.
I hope I can visit one day.
Yes. Oh my gosh. Like, it's just, Dr. Nakia Grayson seems awesome. And I want to put that plug in there. And then thank you again, Efe. This, I think, is 2 hours, oh my gosh, of answering questions. And we're getting a lot of thank you, Efes. This was great.
You're welcome.
Just so much love and appreciation. Oh my gosh, they're just gonna yep, there they go. I think, y'all, we had over 110 people in here at one time, which is wild, and also speaks to oh my gosh, there's so many thank yous, Efe, to the power of online access, which is great. Yeah, any other pearls of wisdom that you want to share before we close out?
I was supposed to find that quote we talked about earlier, and I never got around to it. But I'm going to paraphrase it. If anyone knows the art there, please feel free to put it in. But the quote goes, do what you can with what you have and where you are. You do not have to change the world overnight. You do not have to create this big system. I mean, even myself, my organizing has been very, very, very grassroots, right? And so I do what I can where I'm at with what I have, and you can make a difference. So even if you are an administrative receptionist in a lawyer's office, right, you can put things in the lunchroom, or look what's happening in maternal mortality, or this is how you find a midwife, or talking to your friends and family, telling people to take childbirth education, or learning about sexual reproductive rights. There's a space for you everywhere. And if there isn't, you create that space.
Love it. And Efe, I think you also said this at the very beginning. Am I going to see you tomorrow outside of Woodhull Hospital?
I will be there. I made a couple signs, and I will be there and support. Yeah. I also have a breastfeeding class to take right after. So I won't be there as long, but I'll be there.
Full day indeed. Awesome. Well, thank you again so much, Efe. This has just been such a pleasure. And again, I think 47 questions is what it tallied up to. And that's, everyone had such good questions. So thank you all for asking the questions. Thank you to the student organizers for.
Yes, thank you to the student organizers. Please keep organizing. This was wonderful. Yeah.
And follow Efe and her journey and support her. And let's just get out there and do some good work, y'all. Thank you so much. Have a good night.
Good night.